Plus, there is an event after this. So for those of you that want to go, we want to try to stay on time today. Welcome, everyone. It is April. Welcome to the April version of the JVS Online Journal Club. We are thrilled to have everybody here today. Give me just 1 second to open up the slides and we'll kind of go from there. So this evening, we are having two wonderful presentations of papers from this month's JVS. The effect of after-hours presentation in ruptured abdominal aortic aneurysms, and also the natural history of renal artery aneurysms. And we're thrilled to have our hosting institutions and our author guests, as well as special guests as discussants. From Indiana University, Ashley Gutwin is our faculty. She'll be introducing the topic, and also Dr. Michael Ingram is the resident, the third-year resident who's going to present. Carlos Bachara, who is from Loyola University, and Michael Parker, who is the first-year vascular fellow there, will be presenting for Loyola. We have our author guests. Thrilled to have Dr. Patrick Casey, who is an assistant professor in the Division of Vascular Surgery, and also the second-year vascular research fellow at Massachusetts General Hospital, Dr. Samuel Jasula, who will be answering questions. And then Karen Rockman, who is a professor of surgery and the acting chief at NYU, and Jason Zhang, who is the second-year integrated resident, will also be answering questions from their article. We have two very esteemed guests who will be moderating for us. Thrilled to have Dr. Trissa Bobrowski, who is an associate professor of surgery at the University of Chicago, and then Dr. Adam Beck, who is the division director for vascular and endovascular surgery at University of Alabama. Just some slight housekeeping notes. Please stay muted. Please put your questions and comments in the chat. The discussion moderator will call on you. The event is being recorded for on-demand access. And then, of course, in May, we will be having our online journal event, and we'll be sending out information about that in just a couple of weeks and posting it on social media. So with that, I will stop sharing my screen, and as soon as I can find the mouse, and we will turn it over to Dr. Gutwin.
Good evening, everyone. Can you see my screen?
We can. It looks great.
My name is Ashley Gutwin. I'm one of the faculty at Indiana University, and I want to thank the Society for the opportunity to do this today. We will be presenting on the effects of after-hour presentations of ruptured abdominal aortic aneurysms. So for a little bit of background, this paper really touches on the question of, is surgical care after hours worse on weekends and after hours compared to during the weekdays? And if it is, does it translate into worse outcomes? When we think about this, I kind of divided it into three different questions. Could there be problems with the preoperative care, whether it be a delay in care, given that often the emergency rooms have experienced the highest volume of patients during the weekends and then also after hours, which can lead to delays in transportation, delays in imaging due to the CT scan availability. And then finally, often you have call teams from subspecialists that are in the hospital, requiring them to transport to the hospital to evaluate the patient as well. And then once you get into the OR, you have a few more obstacles. Often you're working with a surgical team that is less experienced in more specialized procedures such as aneurysms, being the surgical scrubs, not being familiar with the procedures, or the nursing staff knowing how to set up for the room, and then also differences in anesthesia at night. And then finally, in the postoperative care, often your ICU is staffed very differently at night during your daytime, whether it be if you have a nurse practitioner team or if you have an on-call team. And then finally, you can have limited access to in-house specialists such as nephrologists and then cardiologists. Ruptured aneurysms are kind of really the pinnacle of surgical emergencies that require emergent care. There's really no indication for delay of care, and so even with the best care, you're up to a 50% mortality, and the SBS recommends that you repair within 90 minutes. Another very interesting aspect of aneurysms is they're technically challenging and very technically diverse. An endovascular repair compared to an open is going to take you a completely different subset of skills from your nursing team, from your anesthetic, from your surgical team and your scrub, and then even your radiologist. So it kind of adds a few layers of complexity. Once again, surgical emergency and any delay in diagnosis, whether it be from the emergency department or imaging, can result in delays in care, which can be deadly. And then also these patients are often very sick when they come out of the operating room, whether they're in hemorrhagic shock and needing blood products, renal failure, or things along those lines that makes their care can be very challenging aspects. When we look at kind of the background of what's been done in the past, looking at the outcomes of ruptured aortic aneurysms during the weekends, we don't really have any good ones from weeknights and weekends combined, but just looking at the weekends. There were two studies, one out of Los Angeles and then out of Ann Arbor in 2012 and 2014 in JVS, basically showing there was a slight increase in mortality during the weekends compared to the weekdays, the Monday through Friday compared to Friday, Saturday, Sunday. But then we have a second set of papers that kind of confuses us a little bit. These two came out in 2017 and 19, and they weren't able to show that difference. They said at the end of the day, they didn't see any significant difference in the outcomes of ruptured aneurysms during the weekends, with the caveat that the one did find that if you had to transfer the patient and there's delays in care with transport, that you would have an increased risk of mortality. So that's where this paper kind of takes us. And if we kind of take a step back and look at kind of overall the hospital's care on the weekends, and there is some evidence even from the New England Journal of Medicine that if you are admitted on the weekends, you have a higher mortality. So kind of a step back. And then also trauma has been able to show that their patients actually do fine on the weekends. So it's kind of a mixed bag. So this is where our paper is kind of taking us and has some questions for us to answer. So I think at the end of the day, the things that I have to ask myself is there a difference in the outcomes? And if there is, what is the cause? Is it something that we could address for, whether it be more timely diagnostics, expediting care, having call staff, things along those lines. So without further ado, I will let Dr. Ingram take over and kind of go over the paper for us. Once I can find my stop share. Sorry, my computer's being finicky now and not letting me stop share.
Well, I think you can stop the sharing for her, maybe, and we can try to.
There we go.
Okay. Dr. Ingram?
All right. So with that introduction, then I'd like to present the paper. So the paper, as she mentioned, is the effect of after-hours presentation in ruptured abdominal aortic aneurysm. So the authors give a little bit of background in addition to that background. And their concern was whether or not patients who arrive after the standard working hours, which for the purpose of this paper, they define working hours as Monday to Friday, 6 a.m. to 6 p.m. and whether those patients who arrive after that receive lesser care compared to those who arrive during their regular workday. And this is possibly due to perceived decreased resources and staffing outside of the regular business hours. So to look at this, the authors chose to ask whether there's a difference in outcomes for patients who present with ruptured abdominal aortic aneurysm, who during the workday or after hours. And again, they define after hours as Monday to Friday, 6 p.m. to 6 a.m., and then all day, Saturday and Sunday. So as Dr. Gutwein mentioned, the SVS does recommend that all ruptured abdominal aortic aneurysms are repaired within 90 minutes of presentation. Thus, the authors mentioned that this is a nice procedure to look at outcomes because it limits your selection bias that you may have. Other procedures that in vascular, such as maybe a bypass or other intervention for acute ischemia, may have a variable indication for intervention. And in those other procedures, patients who couldn't wait until the day would likely have an inherent higher acuity that may lead to inherently worse outcomes. But as we all know, with ruptures, you got to repair it now. So it's a good article or good procedure to study for this purpose. So in terms of their methods, the authors performed a retrospective review of centralized data from 3 major databases within Nova Scotia, all collected between January 2005 to March 2015. The authors mentioned that Nova Scotia has a population just under 1 million, and in the province, all vascular care is delivered at 3 tertiary referral centers. They mentioned that all vascular surgery is performed by a dedicated vascular surgeon during workday and as well as after hours. However, they do mention that only one of the hospitals of those 3 has off-the-shelf endografts available for emergency endovascular cases. They do mention that while the operating surgeon is certainly a vascular surgeon, even on call, the after-hours on-call teams consisting of the nursing, techs, and anesthesiologists may not necessarily have vascular experience. So you just kind of get whoever's on call. Again, as we mentioned, the population was divided into 2 groups, the workday and the after hours group. And then for the purpose of recording time of presentation, the authors went in time preferentially in the order of when the CT scan was performed as defined on the radiology report, and then the surgery operative time, and then the time of contact for the emergency health service, which will abbreviate EHS. And for those of us in the US who may have a different terminology, that's similar to EMS here. In terms of the outcomes that the authors were interested in looking at, their primary outcomes that they chose were mortality prior to surgery, surgical intervention, so whether or not they actually underwent surgery, 30-day mortality, and operative mortality, which they define as 30-day mortality for patients who were offered surgery, and then ultimately hospital length of stay. So after looking through their data, they ended up with 205 patients who presented with ruptured AAA during the workday. So that's about 53% of patients, and 185 patients presented after hours. Of those patients, 129 or 49% underwent operative repair during the workday, and 133 or 51% underwent repair after hours. So already you can see that the distribution is fairly similar between the 2 time periods. Notably, which is, I think, very different than our local practice pattern, is that there were relatively few patients who underwent total endovascular repair. So they only had 15 patients total during the workday who underwent endovascular repair, and 20 patients who underwent EVAR after hours. So ultimately, when you're looking at screen left here, while looking at the clinical characteristics of all their patients, these are all patients on screen left who presented to the emergency health service or the hospital with the diagnosis, ultimately found to have a diagnosis of ruptured AAA. No major differences between the 2 groups, except that the workday group was a bit more hypertensive. And then looking at table 2, this is all patients who were actually offered surgery. Again, fairly similar distribution between the 2 patients. And then ultimately looking at the univariate outcomes in table 3 here, what we do find is that patients presenting during the workday have a slightly higher chance of mortality before surgery, but we'll talk about that in the multivariate discussion a little bit. And then in terms of the 30-day mortality, whether or not they were offered surgery, the operative mortality, all with no significant difference between the 2 groups, and then a slightly increased length of stay in patients who presented during the workday. So this is a nice figure on your screen right here that the authors included in their paper. Ultimately, they started with 579 patients who had a diagnosis of a ruptured AAA. They excluded 119 patients who unfortunately passed away at home, and then 70 patients who did not have any time data to be included. So after splitting them up in terms of the time data, the authors provide a breakdown of who actually had a rupture, ultimately who was admitted to the hospital, who had an operation, and then in terms of their overall chance of survival is listed here in each box. And again, fairly similar between the two groups. And then when looking at the multivariate analysis that the authors performed, ultimately, they found that after hours presentation is not associated with an increased odds of mortality before surgery. So that difference does disappear that we just saw. And additionally, there's no increased odds of operative intervention, 30-day mortality, or operative mortality. The authors did note that one of the limitations of the study was the endovascular capabilities of the hospitals. So they did perform a subgroup analysis of 186 patients who all presented to the hospital that has emergent endovascular capabilities. And then this did reveal similar findings that an after-hours presentation is not associated with an increased odds of those above primary study outcomes. So again, looking at table 4 here on screen left, this is the odds of all the primary outcomes when controlling, as we see in the top there, the mortality before surgery, controlling for age, sex, diabetes, cerebrovascular disease. And then again, that after hours presentation disappears. One possible explanation that the authors gave in their paper, which seems pretty reasonable to me, is that those patients who may be more frail, may be more dependent on others to help take care of them, they may present during the workday because they're actually not found to be an extremis until the morning when their caretaker awakes to see them in the morning. So that may be one possible explanation. And then on screen right here, again, this is the multivariate analysis of all patients who presented to the endovascular capable hospital. And again, we see when controlling for these variables that there's no increased odds of 30-day mortality or operative mortality, regardless of your time of presentation. So like we said, initially, patients who presented during work hours had a higher rate of pre-admission mortality. However, this difference was not evident when controlling for the other confounding variables. No significant difference were seen between the workday and after hours presentation in terms of the 30-day mortality, the operative management, or the operative mortality of these patients. As Dr. Gutwein mentioned and the authors mentioned in their discussion in the paper, there's a fair amount of discordance in the literature demonstrating some conflicting evidence regarding weekday or weekend and after hours presentation, but this paper adds more to that body of work. The authors do mention that this paper, as all papers, have their limitations, that the majority of the limitations of this study would equally affect both the workday and after hours groups, whether or not, because it is a retrospective review, so there's some confounding variables, maybe some misinclusions or some miscoded diagnoses. However, these would be expected to affect the workday group and the after hours group equally. Additionally, it's still a relatively small study performed in an area with a heterogeneous population and low utilization of endovascular repair for ruptured AAA. Does limit its generalizability a bit. The authors recognize this. But in the end, no difference seen between all their primary outcomes on their multivariate analysis. So again, I'd like to thank Dr. Jasula and Dr. Casey for allowing me to present their work. And this was the effective after hours presentation in ruptured AAA. Thank you.
Michael, really nice job. And Misty and Paul, thanks for having me again to moderate. There are some comments that are and questions coming up in the chat, and I'll read those in a second. One of the things I just wanted to point out, and I was interested to get a comment from the authors is that if you look at the hours that you look at on the weekend, that's only 60 hours from that Friday evening to Monday morning, and yet you almost had 50%, exactly 50% of the patients presented during that 60 hours, which I thought was kind of interesting. Or is it exactly, or what are you did this from Friday afternoon to the morning, or how does that work out? And if you just divide it, 50% of the hours for the week, is it 50% of the cases come in, or is there some different there? And then my other question, you've already actually talked a little bit about in your limitations, is that there are obviously ruptures in quotations, and there are ruptures. There are patients who come in hypotensive or maybe even getting CPR, and you have limited information about that in your paper. And I wonder if there's any way, maybe as a future project, to get a little bit more data and look at that. Or are you interested in doing that? And I'm directing this at Dr. Jasula. I'm interested to hear your thoughts.
Thanks for having us, and excellent presentation, Dr. Ingram. I think to answer your question, Dr. Beck, the choice of after hours that we wanted to look at was when you didn't have your primary team, and that in our institution was both at night, so after 6 p.m. until 6 a.m., and then as well was on weekends, where you might have a team that's usually dedicated to ortho or another subspecialty. And that was really what we wanted to test. We knew that there was a quote unquote weekend effect that had been seen in a lot in other pathology, as well as in aneurysm care. And so that's why we picked that distribution. It just so happened that 50, roughly our groups were equal numbered, but that was more of a coincidence. To our knowledge, there's only one study that has revealed a circadian rhythm to ruptured aneurysm, which has yet to be replicated, which found a higher incidence in the morning. But in our distribution, it just so happened that they were roughly equal. And then your second question,
it's just about hemodynamic stability, and
Yes, so it would have been fantastic to calculate a score like the Harborview score, or just get a better sense of the hemodynamics, but the data was just not available. It was very sparse and just not usable. And then even on imaging review, we tried to ascertain, contained versus free rupture. And unfortunately, that was not something we could easily tease out. We wanted to cast a broadest net as possible because we wanted to capture all patients who had a rupture in the province, whether or not they were repaired or even were transferred to another hospital. And in order to do so, we had to combine multiple databases. And then obviously we lost granularity in the data, and we were unable to discern either the hemodynamics or the contained versus free rupture component, which is obviously a limitation of our study, unfortunately.
Thank you. And there were a couple of comments in the chat. I think Dr. Bashara had a comment, sort of a broad question about whether we think we've plateaued in taking care of ruptured AAA patients, or is this as good as it gets? And what are your thoughts about that? Or maybe, and maybe as a follow-up to that, Dr. Forbes' first question is that the study ended in 2015, and the question is whether the adoption of EVAR for ruptures has increased in Nova Scotia since that time, and do you think that would impact the results? And then I'll read his next question after you address that. Do you think that EVAR has been increasingly adopted in Nova Scotia since the end of this trial or this study?
So Dr. Casey can follow up on that, I'm sure, but absolutely, I think the EVAR capabilities both during the day and at night have vastly increased in Nova Scotia since, and so this study is a bit dated in that respect. We were greatly limited in the data we could get through the linking of our databases, and unfortunately, that is one of the limitations of doing research with large institutional databases. There's quite a delay in obtaining the data. But if expect if we were to replicate this study today, we would have a much higher proportion of ruptured aortas repaired endovascularly.
Yeah, I'll just add, the number has certainly gone up. I mean, he and I are in the Canadian system, obviously, and this was, I think I did the bulk of these ruptures really from 2005, probably up until 2015. We slowly got more partners who were more endo capable. Like when I came back, I was the only one. So they've definitely gone up. The last several have been done endo, and we do still do a lot of opens with balloons, but I think that's probably going to help a lot. But it's definitely gone up. Our team has gotten more now. I think every surgeon on call certainly can do an EVAR.
It's not a great argument that this paper doesn't provide a great argument in its current form for having a dedicated team after hours, obviously, but it does make a great argument for increasing EVAR capabilities at these hospitals, which it sounds like you've done since that time, because there was a protective effect for EVAR mortality, not surprisingly. One more question from Dr. Forbes. I think, Paul, your question kind of was answered already, but Dr. Forbes asks, can you expand on pre-hospital differences between daytime versus after hours presentation, like EMS challenges or transport differences? Go ahead. There was actually a third question.
Yeah, so I think in an ideal world, we would have looked at whether there were delays in care. So delay between when a patient first contacts EHS and when they get their CAT scan, and between getting the CAT scan and getting to the OR. Again, the timestamps on all of these were just not usable. We had a subgroup of them that we were able to see, which we've included in the paper, but it was only, I think, about 40 in each category, and that didn't show an increase in delay of care. We've spoken to our EHS colleagues who assure us that the staffing of the pre-hospital care is equivalent in ratio of the need, whether it be during the day, at night, and on weekends, and that they closely adjust the number and experience of the providers to match the need accordingly. But there may be intrinsic delays in care which weren't seen in our study. However, at the end of the day, if the outcomes are similar, maybe those delays in cares don't matter as much as we had initially thought.
All right, one last question, and we'll go to the next paper. There were, this from Dr. Forbes, there were a fair number of patients who presented to the hospital but did not undergo repair. Can the authors talk a little bit about selection criteria for when to go to the OR? Do you have any sense of that from the data that you had available? I know, Patrick, you might want to field that.
I might, so the way it works, and once again, similar to kind of probably Tom's experience when he was at Western, is the patients will come, they may go to a smaller hospital, and then they may there are a few little stops on the way, and as everyone knows, you're on the phone, and if they might have been, quote, admitted to hospital at some other hospital, but if they're dying, they just may not have been even transported to our center. It's rare. I got to say, it's pretty rare for someone to actually get to our hospital and we don't operate or try anyway to start. Sometimes they're pretty short cases, but typically if they get the ambulance or the helicopter, they come right into the OR. But I think a lot of those, and Sam would know better, but a lot of those were probably, they made it to their kind of semi-regional hospital, and then they were just so sick they didn't make it in. Yeah.
Thank you.
Of patients who were assessed in hospital who didn't get a repair, there were only 3 in the workday and 4 in the after hours group that did not get repair and survived. We obviously thought that was odd. And when we tried to dig further in the data, that there wasn't much information as to what happened to those patients. So we expect 100% mortality without repair if your diagnosis is correct. Here we had a 94% and a 90% mortality without repair. So that certainly is a gap in our understanding, either of the diagnosis or of the natural history for those patients.
Well, thank you. Thank you for a great discussion. And I think we'll next go to Dr. Bachara.
All right. Hi, thanks for having us. It's great to see everyone. So we're going to talk about renal artery aneurysm. I'm going to just provide a brief introduction. And our first year fellow, Dr. Parker, who joined us from Innova Fairfax, will be presenting a paper by Dr. Rockman and the co-authors from the NYU group. So renal artery aneurysms, the real incidence is actually very low, less than 1%, actually much less than that. Usually it's more common in females than males in their 50s or 60s. And part of it is, in relation to FMD. Maybe that's why we believe it's more higher in females than males. And 1/3 of those patients are smokers. So most are asymptomatic. 30% could have symptoms like uncontrolled hypertension, abdominal flank pain, as well as hematuria. One thing that's important to point out is when you see those patients, 1/3 can have extra renal aneurysms, abdominal followed by splenic, thoracic, iliac, and visceral aneurysm. So keep that in mind. So our society put the guidelines, which I'm sure all of us are familiar with. I'm just going to point out some few important ones. Is that first, it changed from the previous guidelines from 2 to 3 centimeters to be repaired in an acceptable patient risk. The recommendation is a 2C. Obviously, ruptured have to be repaired with recommendation of 1B, and then patients of childbearing potential with non-complicated renal artery aneurysm and acceptable operative risk. Also, the society suggests treatment regardless of size, which is a 2B recommendation. And finally, patient with medically refractory hypertension and functionally important renal artery stenosis, they also recommend treatment. It's a 2C recommendation. So, like I mentioned, our fellow Dr. Parker were presenting the paper on natural history, which I think is a very good paper that talks about the growth and natural history of renal artery aneurysm, as well as from Dr. Rockman and her co-authors from NYU. I'm going to actually open the discussion. I would like to see if anyone has any exceptions to the 3 centimeter rule. How about patient with 1 kidney? I actually have 2 patients that I've treated so far with 1 kidney, born with 1 kidney, and I'll admit they were not 3 centimeter, but we can talk about it during the discussion. And finally, as at least I do extrapolate from other pathology like abdominal aneurysm, we always say 1.5 to 2 size a normal vessel, while most renal arteries are 5 to 7 millimeters. And 3 millimeters, that's a really increase in size, which when the recommendations changed, it made me a little bit unease. But again, we all practice evidence-based medicine, and that's why we have this journal club, so we can discuss it further. But I'll admit it made me feel a little bit, uncomfortable with the new recommendation. So I'm gonna stop sharing and let our fellow Dr. Parker present the paper.
Did that do it? All right. So we've already presented the paper, so we'll just jump right into it. This is a retrospective review of 331 patients with 338 renal artery aneurysms. And the primary objective was to see what the growth rate was for these patients. And 137 of those patients ended up having follow-up scans that they could use to look at the growth rate. They also wanted to look at, freedom from rupture and interventions and how those interventions went. So background, like Dr. Bachara discussed, it's uncommon. It's more common on CT scans, likely because we're scanning people that have a higher likelihood of having the disease, even higher in angiograms. So this was a retrospective cohort review. The authors queried their radiological database for renal artery aneurysm related terms.
once patients were identified, the authors, 3 authors, it sounds like, reviewed each scan and made sure that the findings were appropriate, and they measured each aneurysm independently to make sure that their sizings were appropriate. It includes patients from 2015 to 2019 that were over 18 years of age and who had a renal artery aneurysm on their CT scan. Patients without follow-up were excluded. So this is kind of the flow chart of how their patients were split up. So starting with those 331 patients, 50 didn't have follow-up. The 281 had clinical follow-up, 137 had radiologic follow-up. And then on the bottom row, I think something that was interesting was patients who had a diameter over 25 millimeters were only 4 patients. So out of that, less than 4%, so a very small proportion of patients that would meet the criteria, at least on a size basis. Digging into the results, there was a right-sided predominance. Most were fusiform, and then most were located at the hilum, with very few in the proximal and mid portion of the renal artery. The average age was 71 years old, as you can see on the right side, and then it was associated with obesity and some other things, as we'll see a little later on. So mean clinical follow-up was 41 months, radiologic follow-up was 26 months. And so for clinical follow-up, no patients in this study had a rupture. On those that had a radiologic follow-up, slow growth was noted throughout the cohort. So only 31.4% experienced growth. And within that group, the mean was 0.23 millimeters a year, with a median growth of 0 millimeters per year. So very slow growing, and most of these aneurysms were not growing at all. 8 patients underwent intervention, 4 of them for size criteria greater than 2 centimeters, and 3 of them for symptoms of hematuria or abdominal pain. The 8th one, I don't think they're able to figure out why exactly the intervention was done. Looking at multivariate regression, obesity was associated with growth, which has been shown, extrapolating from AAAs, that's also been seen before. And then active tobacco use was nearly associated at 0.06, but not significant on this study. So looking at their discussion, I thought it was interesting to look at some of the studies that they had brought into their paper. These, of course, are the guidelines, which Dr. Bachara talked about. But the recommendations for women of childbearing age, the best study I could find was only 18 patients in the entirety of the English literature at the time of this study. And of them, only 44% of mothers and 22% of fetuses survived. All of these were over 3 centimeters. All of them were in the 3rd trimester, and all had no past medical history, which I thought was very interesting. And then there's another study from the vascular, what's it called, the Low Frequency Disease Consortium, and they had 865 aneurysms in 16 institutions. They followed those for 10 years, and there's a lot of data in the study, but something that I found interesting was there were 3 deaths in the intervention group, but no deaths in the rupture group. There were 3 ruptures transferred in this 10-year period, and all 3 of them survived. And then there were 3 patients that died from elective repair. So it just, to me, highlighted what they're talking about in the study. This is a slow-growing group of aneurysms. The natural history is pretty benign. 3 centimeters seems an appropriate cutoff. And routine follow-up should really be the mainstay of management in smaller aneurysms and those that are asymptomatic. Thank you so much for your time.
All right, Michael, thank you very much. That was a great presentation. And thanks, Carlos, for starting off the discussion. I have a couple questions as well about this. I think it's really interesting that over 2/3 of the patients, or about 2/3 of the patients, had right-sided renal artery aneurysms. I wonder if anybody has sort of theory behind that. And to kind of go along with that, with Carlos pointing out that it's most frequently encountered in women, but we have always attributed that to the higher incidence and frequency of FMD in women. This paper showed that there weren't that many patients who had FMD. So do we have alternative explanations for that as well? And I welcome the authors. We have, I think, Dr. Rockman and Dr. Zhang with us.
Yeah, I'd like to let a first author, who is our second year resident, tackle those questions if he'd like to.
Sure. Yeah, thank you for that presentation, and thank you again for the opportunity to present or have this paper presented. I don't have, unfortunately, a good answer for why there might be a right-sided predominance. I think I did see that in several other papers as well. I think we looked at sidedness as a potential like prognosticator for growth, which it wasn't. So I'm not sure that it's clinically relevant. I don't know. I don't have a good explanation as to why that might be, though. With regards to the FMD, I did see in the literature that other people had proposed that potentially as sort of a hypothesis as to why there may be more female predominance. Again, I think we had like 3 patients with suspected FMD in this cohort, and none of them grew at all. I'm not, again, totally sure why this may be. I suppose there could be a matter of hormonal influence, but I don't know if Dr. Rockman wants to chime in.
Yeah, I mean, I'm happy to. You know, these are obviously very interesting lesions, and they're rare, but they're not that rare. So all vascular surgeons see these. Most of them, of course, are incidentally noted, but I think it's important to step back for a minute and talk about even the guidelines that we have, right? Because it's very difficult to write systematic guidelines on something like this, which is a rare illness. And as mentioned previously, the literature is skewed towards either ruptures or patients who had intervention. It's very hard to get any natural history on these lesions. And that was really our impetus for trying to do this. You know, if you think about this, I tried to figure out at some point what the denominator of CT scans performed at our institution was during that 5-year period. And I couldn't even come up with an estimate in any real way, so we didn't report it, but it's obviously enormous. So these are in fact rare lesions. If I'm not mistaken, when these guidelines were, before they were published and they went out for public review for members of the vascular community, I think at least for one category, it may have been this category and the splenics, I'm forgetting, that the initial guideline recommendations had 2 centimeters. And there was a lot of protests from the vascular community saying, well, that's too small. So I don't think you're ever going to find a number that makes everyone happy. Dr. Bachara said, well, is this 3 centimeters absolute? I think, of course it's not. These are just guidelines. And many of us will look at these scans and there's just something funny about some of these lesions, whether they're very saccular or you suspect that there's something weird in their morphology that makes you feel uncomfortable watching them. And I think that clearly happens. And that probably is what leads to some of these repairs. And I think with all visceral aneurysms, you have to weigh the natural history or what you know about it against what the repair is, right? If there's a lesion that we think is very amenable to a stent graft, most of us would feel a little bit more aggressive about those lesions despite the size criteria, where if it's a lesion in the hilum that's going to require, you know, an ex vivo repair, most of us are willing to watch these things. You know, as far as the right-sided tendencies, I don't have a better explanation. I assume it's something in the morphology of the vessel of the right renal artery. And I think, you know, the female predilection for certain visceral aneurysms is well known. And, you know, for those of us who are old enough to have seen one time in their career a rupture of a renal artery aneurysm or a splenic artery aneurysm in a pregnant patient, I mean, these are cases that really stay with you. I think I'll stop there and see if there are other questions.
Thanks. So a couple of questions that we have here in the chat. We wonder if the authors can provide any additional information on repairs in the context of hypertension. Are we convinced that that actually helps alleviate hypertension and helps preserve renal function down the road?
If you ask me personally, I'm not personally that convinced. I guess there are sublesions that you might have evidence of small renal infarction or evidence of atheroembolization or something else in the morphology that makes you think that that's occurring. But of course, hypertension is so prevalent in the general population. My I think it's hard to make a perfect correlation. Maybe others feel differently.
And then I also wondered, and Dr. Forbes brought this up as well, you did all of this great work to look at the natural history of these growth rates, and we know that they grow so slowly and they have a low propensity to go on and require intervention. So should that potentially change the interval that we image these patients? And then kind of as an additional question to that, I was really interested that it looked like your imaging was always CTA based. I frequently will just do duplex for these patients. And I wondered what the role was for doing ultrasound instead of CT for following patients.
You know, in my personal practices, whenever I see anyone for the first time with a visceral aneurysm, I always try to ultrasound them in the office, because if you can in fact see the lesion on ultrasound, that's a much better way to follow them rather than subjecting potentially young patients to yearly CAT scans, which I think really becomes unfeasible at some time, particularly when some of these patients are younger. I don't know, Jason, do you have any thoughts on that?
Yeah, the way that we kind of collected the data, we like searched into a radiology database specifically for CAT scans. So we weren't able to capture anyone who say was in the vascular office and got a renal ultrasound. So that's kind of why our entire data set is with CTs. I don't know that necessarily patients would have to get one every year per se. It could probably be potentially every couple of years, just given how low the growth rate is. That we didn't see any significant difference in the growth rates as the sizes of the aneurysms went up. That being said, we didn't really have a very big sample size for the larger aneurysms. And so potentially the larger they are, they could be imaged more frequently. But I certainly think there is a role for duplex. We just didn't capture that specifically in our data.
So Jason, what additional features then, what are you able to glean about additional features other than size should we be concerned about when it comes to treating these, renal artery aneurysms? And, Dr. Bachara really wants us to answer for him. Do we need to wait for 3 centimeters with patients with a solitary kidney? He has this question and he's demanding an answer. So let us know, please. We're dying to know.
I think ultimately, my personal answer is ultimately this is the surgeon at the bedside kind of thing. And I would weigh it against the morphology of the aneurysm. Certainly in someone with a solitary kidney, you are more concerned. On the other hand, I don't think having the solitary kidney would make these more likely to rupture in any way. But certainly ones that can be fixed routinely with endovascular means, I think those are reasonable things to do. And I also find, at least my own personal small series over a career, the ones that I've done open, you're always kind of worried about them, but they're not typically as hard as you think they are, right? It's usually a little aneurysmorrhaphy or plication, particularly if it's a saccular lesion. So I think in appropriate patients, one shouldn't hesitate. So my answer to the question is, I don't think you always have to wait till 3 centimeters. And this is a fluid situation in a rare disease.
Great. And then just for people who aren't monitoring the chat, Dr. Dahlman also pointed out that in databases, we see that stem fractures are more frequent in the left side rather than the right. So maybe the role of the IVC and mimicking movement. Maybe there are some sort of physiologic or anatomic considerations that lead to more aneurysms on that side. So that's an interesting thought as well. I really applaud you because when you look at your data, you only had 18 patients who were lost to follow-up of all of your patients who had clinical follow-up. And I guess the question is, how do you capture those patients and how do you ensure that they actually do get the follow-up that they need clinically? Because it looks like the follow-up and the interval was really great.
I do think it's important to note that most of these patients were never seen by a vascular surgeon. We got this denominator of patients from searching a radiology database. And by the way, Dr. Zhang has an upcoming presentation at VAM from the same database on the splenic artery aneurysms, which I think, Jason, is a little over 800 patients. So it's a radiology database. Not all these patients were referred to a vascular surgeon. Most of them weren't. And there are probably people out there that are getting a lot of CAT scans for other reasons that have no idea what the size criteria, for visceral artery aneurysms or when someone should see a vascular surgeon. So I think that's something important to take into account when you look at these. We had no control over the follow-up, really.
So do we think that there's a utility to having some AI within our radiologic sort of databases that alert people and have like best practice alerts when you see, terms like aneurysm or something like that? Should we be doing things like that for follow-up for patients?
I think those are interesting thoughts. Certainly the one of the values of the EMR might be to do something like that.
Just going kind of off somewhat anecdotal, like we didn't actually measure this specifically, but I would say probably only 10 to 20% of the patients who were actually diagnosed with aneurysm on the imaging were seen by a vascular surgeon. So I think there is probably some room to improve that. I don't know exactly how that would be done, but I think certainly there's like a large hole where patients are not being followed up on for these lesions.
Yeah, we see that not just for these lesions, but for all kinds of lesions. You have people who come in with like 8 centimeter AAAs that have had AAAs for 8 years that nobody has been following, and they've been getting CTs after CTs. So I think that really is certainly an area of opportunity, an area of improvement for all of us.
Well, thank you. Thank you very much for that great conversation. I want to thank our authors for being here. It always makes for such a much better, robust conversation when we do have the authors here. Our two hosting institutions, Indiana University and also Loyola University, very grateful for you guys being here tonight. And then, of course, Dr. Forbes and Dr. Dahlman for joining us, and then our moderators, Dr. Beck and Dr. Babowski. So we will see you all in May, and we will see some of you a little bit later. So have a good night.
Good night.
Thanks, Misty.